Hello, everyone. I'm Christy Rizk, Senior Editor at GenomeWeb, and I'll be your moderator for today. The title of today's webinar is Liquid Biopsy in Metastatic Breast Cancer, Recognizing the Bad, the Good, and the Ugly, and our sponsor is Menarini Silicon Biosystems. Our panelist today is Dr. Massimo Cristofanilli, Professor of Medicine and the Associate Director of Translational Research and Precision Medicine at the Robert Lurie Comprehensive Cancer Center of Northwestern University. You may type in a question at any time during the webinar. You can do this through the Q&A panel, which appears on the right side of the webinar screen. If you look to the tray at the bottom of your window, you'll see a series of widgets to enhance your webinar experience. And with that, I'll turn it over to Dr. Cristofanilli. Please go ahead.
Good morning, everybody, and thank you for participating. First of all, this is obviously a testimony of the interest in this particular topic, especially during this difficult time. I think liquid biopsy is certainly one of the most important areas of development and diagnostic development in the last few years. And what I will clarify here is that my presentation will focus on the development of these technologies, particularly with regard to the answer to a specific need in clinics. And the clinic has a major need in regarding to identification of metastatic breast cancer with aggressive features and trying to understand the biology of this disease in order to improve therapies. So there are different information we can get from liquid biopsy. Some information will obviously tell us about patients that will do better over time. Some other the patient have a very aggressive disease for which we need to focus our resources and our development in better drugs. And some others will do probably much worse, but we do have some hints with regard to combination regimens. So the major needs that we have, if you look at the breast cancer statistics in the last few years, there's certainly no change in the US and in the world. We still have a large number of women that die of metastatic breast cancer. And this is a fact, and if you look at the statistic over the last 10 years, this number of deaths has not decreased significantly, in spite of the increase of cases. So meaning that there is more diagnosis of early disease for which we have treatments, surgical treatment, radiation, and chemotherapy, and endocrine therapy. But for patients with advanced disease, our impact on survival is still not that strong. And this is even much worse, a much larger impact worldwide when you do have developing cancers that appear to have a larger number of patients that present with locally advanced or metastatic disease at initial diagnosis. So which is the impact on survival of initial diagnosis? You can see by organ sites, the second one being breast. Obviously, when you diagnose a disease very early on, localized, you have a very high chance of cure. A regional involvement with lymph nodes, the chance of cure decrease, but it's still very high because we have effective adjuvant interventions. But when you go to distant metastasis, so we are talking about de novo metastatic disease or presentation over recurrence, the survival is really small, and the 5 years is approximately 20–25%. So this is a significant problem, and one is due to the fact, obviously, that we don't have major diagnostic that allow to discuss, to develop, to identify this disease very early on, and the other one is the therapy that are probably not target to the problem that we are facing, that is the metastatic disease. So when I got involved first in the development of the cell search many years ago with a publication in 2004, I wanted to address a specific questions. In the clinic, we do have patients diagnosed with metastatic disease that do better compared to others, but we have limitation in understanding who the patients will be. And it would be great if you have a blood test, will identify and report to us that information so that we can focus even more resources on the patient with more aggressive disease. So the development of this technology was toward these specific questions. Which patient do worse when we count the circulating tumor cells? It was never meant to capture all the cells that we have in the blood. I think this was actually an important point at that time. And some research took over the development of other technologies that would capture more cells. But a fundamental question many other technologies have not addressed yet. 5 CTCs define a group of patients with a more aggressive disease compared to less than 5 CTC. And this is one blood test before treatment. This is an independent predictor of progression-free survival, overall survival. So in the last 16 years, there have been a number of steps that allowed us to understand the impact of this information. First of all, if you look at the bottom part, we look at the comparison with imaging, and I think I will spend a little bit more time on that information because it's really relevant. Between 2006 and 2016, a number of other studies, prospective studies, were conducted in different parts of the world, in Europe, in Asia. All of them demonstrate the same value, the same prognostic value, the cutoff of 5 CTCs. And there was also a pool analysis that put together most of the data in Europe as well in the US, showing that, in fact, this cutoff stands very strongly, irrespective of the population characteristics. There have been a number of studies looking at primary disease, and the CTC and primary diagnosis appear to be prognostic with a different cutoff. The SUSSEX trial was a large trial conducted in Europe. And then a number of other retrospective studies, so correlative study associated with our prospective ECOG studies, looking at, for example, CTC stratification for late recurrence, an important aspect of metastatic disease in patients with estrogen-positive disease, and the identification of the predictive value of CTC in metastatic, if they can predict which patient will need chemotherapy instead of endocrine therapy when you look at, again, at hormone receptor positive. The final paper was the consensus that we published just last year, and is a consensus of how to use CTC for staging of metastatic breast cancer. We spent a little bit more time discussing that paper. On the upper part, you see the different steps in regarding to approval, FDA approval of different liquid biopsy tests, not only in breast cancer, but also lung cancer, colorectal cancer, prostate cancer. The most recent for breast cancer, very important, is a PHEK mutation associated with the approval of a targeted therapy. And over these years, the last few years, there's been also a clinical adoption of NGS liquid biopsy clinical tests. So the first question you ask, what's the clinical meaning of CTC detection? So we run a test in a patient with metastatic breast cancer. We have a number, and we are facing with this information based on these studies. But what do we do with that information? And I think addressing the first question is really important, particularly for many physicians that are not familiar with it. What's the clinical application? And as a clinician, I usually look at the imaging study as a way to start to decide which treatment patients should be received. So I want to bring this case just because it was a very important case at the beginning of our study to show us essentially what the importance of this test. So this is a case of a patient with a triple-negative breast cancer metastatic to the liver with liver abnormality, for which you will think, obviously, there is a very bad prognosis, a very short survival. We know from all the studies that look at the sites of recurrence as a prognostic factor. And this is a different patient, but with similar features. The only difference is this woman is similar age, but different subtypes. The first one was a triple negative. The second one is hormone receptor positive luminal subtypes. She did not have a liver dysfunction. She would just progress on endocrine therapy. So if you were to look at these images, you will not really figure out which patient would do worse or which would be the next response to therapy. And you would just say that these patients have worse outcome, but the ER positive may have more therapies available. But what happened is that at that time, we find out that this woman went to the study, received multiple lines of therapy, and responded to this therapy one after the other for almost 2 years. She had 0 CTCs at the time of enrollment in the study, and we didn't know at that time what this meant, but in retrospect, we found out that, in fact, not having CTC, or even in this case, 0 CTC, is a good predictive factor, not only prognostic factor. This woman had minimal liver involvement, as I mentioned, but she progressed very quickly. And the only difference with the other one, if you just forget for a moment the image, is that she had 177 CTCs in 1 tube of blood, 7.5 cc. So clearly, is a different biology underlying to different disease. And you would not expect that a patient with such an aggressive triple negative will survive even one line of therapy compared to ER positive. So clearly suggesting that CTC can actually help you in deciding and stratify patients at the moment that they progress above and beyond imaging. Interesting, in the pivotal study, when we had 177 patients, we also had a very careful central review of the imaging because we wanted to compare, address this question, how is imaging compared to CTC in predicting outcome? And you can see on the left side of the slide that there were two different groups defined by both the CTC and the CTC at baseline and the imaging response. The group 1 was the one that had a response and less than 5 CTC. So if you have a response and you have less than 5 CTC, you have a reasonable probability of survival. And I think this reflects the first patient that we saw on the previous slides. The group on the bottom actually is the worst group. But not only you have no response by imaging, no anatomical response, but you do also have more than 5 CTC. So clearly, this is the worst group of patients. No change in the dimensional lesions and more than 5 CTCs. But interesting enough, the two groups that you are in the middle are quite different and less than, and you will not probably believe, this was a surprise for us, that the more than 5 CTC, in spite of the imaging response, actually does worse. So this is the first study that actually confirmed what our observation was when we were running this trial, that CTC can provide information above and beyond the imaging. Now, on the right side, we have comparison with PET-CT. And I will show you just a case before we go into details of that particular study. So we use PET-CT, and many times we've shown that PET-CT is the best imaging for bone disease. So this is a patient with an extremely high involvement, multiple locations in the bone. She's symptomatic, obviously, particularly for the pelvic lesions. And this is what happens 3 months later with the treatment. She had to be started on chemotherapy because of the symptoms. So you would say that the imaging suggests she had a great response. She must feel better. We have changed her outcome, and probably she will live longer than expected at the beginning. But this massive bone disease was associated with a number of CTC that was so high that we actually stopped counting. And this is something that will come up in other studies that we have run and retrospective analysis, where CTCs are particularly common in patients with bone metastases, when bone metastases are one of the sites of recurrence. So when she had a response, she had a drop in CTC, but this never went below 5. So the disease was aggressive to start with, remain aggressive because you, in spite of the imaging response, you did not have a significant drop in CTC. And in fact, she developed leptomeningeal disease, and she progressed very quickly. So this is another application, a comparison with PET imaging with regard to prognostic and prediction of metastatic disease. So this is exactly what we have on the right side of the slides. We compare the 4 different groups. In this case, are the one with more than 5 CTC and less than 5 CTC. They have different response to with PET-CT. So even if you have a complete response or a partial response with imaging, but the CTC remains over 5, your outcome is worse. So the summary of this slide that CTC provide an important additional information compared to imaging study at the time of initial diagnosis or any time the patient is going to change treatment. So this is, again, a reminder. And then we went back and we asked the question, is this true for every line of therapy? And because we know that the longer survival is the patient that has the best therapy and get the best response at first line, retrospectively, this is the database that we built at MD Anderson back in 2010. And we asked the question, a patient of first-line metastatic disease that began with endocrine therapy because ER positive, chemotherapy alone, or combination regimens. At that time, we even had bevacizumab available for our patients. What happened in terms of outcome if I use these treatments and stratify the patient based on CTC detection. And you can see that the patient with endocrine therapy alone, they have CTC, they don't do very well. Even though the number was small, there was an indication that a single agent endocrine therapy was probably not going to be the best treatment for these patients in terms of progression-free survival, overall survival. Chemotherapy alone was obviously a little bit superior. And we also evaluated the combination chemotherapy appeared to be better than single agent more than 5 CTC, but this was not confirmed or evaluated in other studies, suggesting that for patients with more than 5 CTC, there is an intrinsic resistance to the current standard therapy, and we need to do better. And we'll get back to this later with some of the studies and some of the other observations. So the last point that we want to clarify is obviously what happens to the patient that have more than 5 CTC, why they do worse. And the one thing that obviously makes everybody concern about the progression is the type of progression that you see after you have the initial diagnosis. And as you know, even patients with bone metastasis eventually develop visceral metastases and can go to liver failure or respiratory failure. And so the first and most important observation, we went back and really counted and looked at the specific type of disease at progression. So when the patient with more than 5 CTC has a progression, is more likely it's going to be at different sites in a different organ. And so this means that visceral metastases develop more frequently in patients that have more than 5 CTC, responsible for their faster progression, resistant to treatment, shorter survival, and obviously this is the type of patient that will have chance for drug development, new therapies. If you look at the bottom of the numbers, you see that the patient with less than 5 CTC that doesn't develop visceral metastasis or less frequently, you have a median survival at that time of 57.9 months. And I want to keep in mind this high number because this is going to be something that will come back with regard to our consensus paper. So here we are now with this information of CTCs enumeration that not only is a simple prognostic factor, but provide you information on top and beyond the imaging studies, on top and beyond more in terms of the different type of therapies, and somewhat provide some predictive information about the response to these different modalities, and then certainly predicts the development of new metastases. So can we start thinking about CTC enumeration not simply as a blood test for like any other marker, but as a tool for stage 4 stratification? So in order to do that, we had to really go through databases that were available outside our institution and putting together this database with a specific goal of demonstrating this stratification. This was a retrospective effort, international study, EPAC mentioned before, and MD Anderson database. There were individual data patients across 18 centers, more than 2,400 patients. And we were just focusing on the CTC collection at baseline before starting treatment with long-term survival. And so the design of the study is outlined in this slide. We look at the patient with metastatic breast cancer, had a CTC collection, a baseline with the source search enumeration, and had survival data. The two databases provide approximately 2,400 cases, and our hypothesis and objective was to stratify patients according to the CTC counts in two different subsets. The indolent, we will call stage 4 indolent disease less than 5, and more than 5 CTC stage aggressive. And we will look at this. If this was true, this stratification must be present in metastatic breast cancer, no matter if it's de novo or recurrent, irrespective of the site of disease, visceral versus bone only, irrespective of the subtype, hormone receptor positive or luminal type, HER2 positive, triple negative, and irrespective of the line of therapy. If all these conditions are met, we do have a new way to stratify patients for stage 4 disease. So we look at the first questions, and you see here that CTC were prognostic for overall survival. They were in the two different group analyzed individually, and they were also in the combined analysis. And they were also in the de novo versus recurrent disease. Now, the overall median survival was 36 months for indolent disease versus 16 months only in aggressive metastatic breast cancer. There is a 20 months median overall survival difference. This is extremely important, clinically significant, clinically impactful, and this is something that we have to deal with. So metastatic sites, I mentioned before that usually in visceral metastasis, we believe this group of patients have a shorter overall survival, and bone-only disease, in fact, may be considered more indolent. Well, this is not really true if you have more than 5 CTC. So if you have a stage 4 aggressive, your survival, even if you have bone disease, is much worse compared to not having or belonging to the group with indolent disease. And of course, this is particularly true in patients with visceral localization, similar to the 2 cases that I showed you in the prior slide when we were comparing with imaging study. Then we look at the subtypes, and this is obviously important because we know that patients with triple-negative breast cancer do worse in general with ER-positive disease and HER2-positive, where we have many types of therapies. So I want to draw to your attention, particularly for the group of patients that is the most common, and this is the group of patients that is hormone receptor positive. The median overall survival for a patient with a stage 4 indolent disease is actually 44 months. For a patient with stage 4 aggressive hormone receptor positive, is only 17 months. This is pretty concerning because in general, we think that we have opportunity for a number of different therapies for this particular patient's populations. So just clinically speaking, you start thinking now about the concept endocrine resistant, endocrine refractory disease. How many of these patients that we consider endocrine resistant belong to the stage 4 aggressive? We will discuss this a little bit more in details later. I want you to also pay attention to the triple-negative breast cancer population, stage 4 aggressive versus stage indolent. And you can start thinking about the current therapy that we have. What will happen if we treat a patient with a stage 4 indolent with a combination with immunotherapy, with checkpoint inhibitors, versus a stage 4 aggressive? There should be a different way to address treatment for these patients. And has this any impact on the results of the trials that we had already established? So this is showing the multivariate Cox regression analysis where the CTC enumeration is the stronger predictor of prognosis. This is irrespective of the different subset regarding the age, the subtypes that we talk about, the site of metastasis, the line of treatment. I didn't show it to you, but it was exactly doing the same behavior and the type of metastatic recurrence. So it's clear that from this analysis that we do have a test that allowed us to stratify patients in 2 different prognostic groups. And this may have enormous implication in the way we address treatment for patients, in the way we plan treatment for patients, and also in the way we plan monitor for patients. Now we'll get a little bit more on this a little bit later. So now that we have established that the CTC are just certainly more than a prognostics test, how do we use the CTC-based stratification, and why this matter in metastatic disease? Well, there are a couple of questions that we can address, or at least thinking about addressing. We know that one of the major advantages in early breast cancer, since you have diagnostics tools, is de-escalation, right? Oncotype and MammaPrint identify patients that have a lower risk, and then they treated just very well with endocrine therapy and not with chemotherapy. So this is already something established, standard of care in early breast cancer. But in metastatic disease, we are not used to think that way. We always say that the goal of treatment is palliation, and every patient gets the same treatment. For example, for patients with hormone receptor positive, now the standard of care is a frontline CDK4/6 inhibitor for everyone, and combination chemo HER2 targeted therapy for HER2 positive. maybe a triple combination for triple positive and chemotherapy with or without immunotherapy for triple negative. But let's take a step back and start thinking about a stratification. We have an indolent metastatic breast cancer, hormone receptor positive disease. Assuming that these patients, in fact, because they do better, are enriched in endocrine sensitive disease, and we don't have proof of that, there is probably a larger fraction of bone-only disease, especially oligometastasis. Can these patients be treated with single-agent endocrine therapy? Can we assume that this is a reasonable question to ask prospectively? What about the aggressive, stage 4 aggressive metastatic breast cancer, hormone receptor positive? We look at the number, the median overall survival is much shorter than in the group with indolent disease. But can we assume that this cohort is actually enriched on endocrine resistance, visceral disease alone or the combination? So we start thinking about if this is true, or at least partially true, maybe the way we develop clinical trials or we actually address efficacy studies is not correct. And let's go and look at one of the studies that's probably the most significant in the last few years. This is the MONARCH 2 testing one of the best CDK4/6 abemaciclib in combination with endocrine therapy. We know that this study was a prospective phase 3 randomized 2-to-1 study looking at pre, peri, or postmenopausal patients with endocrine resistance clinically defined. And how is this defined? Relapse on neoadjuvant, all within 1 year of adjuvant endocrine therapy, and progress on first-line endocrine therapy. These patients were not exposed to chemotherapy, and they have now received MO1 and endocrine therapy. We know there were stratifications part of that are the same that we just talked about. The metastatic site of recurrence, visceral, bone only, or others, and the endocrine resistant, primary resistant. So compared to single-agent endocrine therapy, there was an overall survival advantage. The group of patients treated with single-agent had a survival median of 37.3 months, the combination 46.7 months. This was statistically significant, adds a ratio 0.75, 25% improvement in overall survival. And when you look at the overall survival by metastatic sites, you see the impact is probably a little bit larger on visceral disease, less or actually not evident in bone disease, only in others. So driven primarily by the most clinically aggressive in the visceral sites. And when you look at the overall survival by the resistance, as was defined in the study, see patients with primary resistance clearly do better when you have the combination with a single agent. Secondary resistance, and this for maybe for the short follow-up or for other reasons, do not appear to have a significant improvement, at least in the same magnitude. Numerically, there was 8 months difference. So wait a minute. My question is, if you look at the CTC stratification in patients with indolent versus aggressive, you see a much larger magnitude of difference simply by knowing the number of CTCs compared to the MONARCH 2 that treated for what we see, or we consider an unselected population, selected only on clinical criteria and not on any other use of molecular test or even stratification test. So the question would be, what would be the impact of this particular treatment in a population that has been stratified by CTCs or in 2 different stage 4 disease? So we had simulated this. We had developed a model for CTC-based stage 4 indolent aggressive simulation model so that we can predict in the context of every phase 3 or even prospectively designed how this group of patients will behave if the magnitude of impact of the treatment would be the same. And I think this is probably one of the ways in the future to tell us what to do in patients with more aggressive versus indolent based on a CTC enumeration stratification. But of course, in this era of liquid biopsy and biomarker, we definitely need to incorporate biomarkers of CTC, of cell-free DNA in our decision process, particularly when we talk about endocrine resistance. So we started to look into, a few years ago, the ability to identify biomarkers or test biomarkers in CTC. So of course, 2 questions very obvious are, this CTC express ER, and there is an ESR mutation that we can measure in CTCs. And so this was a study that was conducted, as I mentioned, back in 2015 and published in 2017, where we select metastatic breast cancer patient estrogen receptor positive, patient that had more than 5 CTCs, and happened to be that the majority had less than 20. We had a single cell isolation after we did the ER staining using the 4-channel or the cell search, and collected single cells looking for ESR mutations. And we were able to identify, this is just to summarize the ESR expression on the left side of the slide, and the ESR mutation with the most common frequently allele, Y537. And this was actually interesting because there was heterogeneity in the ESR mutation when you look at the CTCs. But these were patients that have developed endocrine resistance, and show that we can actually get 2 types of information, enumeration with biomarker expression, ESR, and also mutation analysis. So proof of concept, but very relevant for what we do today. From there, we started to really combine cell-free DNA, circulating tumor cells to understand, first of all, what is the correlation in terms of prognostic features. We start to see that the patient, they have more mutations, and they have a higher allele frequency, appear to be worse, and this is somewhat overlapping with the CTC enumeration, meaning that the CTC enumeration is underlying a more complex biology. That's why these patients do worse. And this is Dr. Rossi, that was a visiting fellow in our institutions. This is actually summarized a little bit more in details. The percentage of cell-free DNA associated with CTC number, in a way suggesting that CTC is a detection of more aggressive disease that reflects not only metastatic potential, but also some level of tumor burden that is better characterized by cell-free DNA allele frequency detection. The other important question was regarding the metastatic sites. I think putting together the information regarding the CTC particular presence in the bone metastatic disease and the different mutations, we were able to draw a map of which is the type of organ that is more characterized or more predicted by a specific combination of mutations, specific mutations, and CTC numbers. And I think it's clear and confirmed again that the bone involvement is always characterized by high level of CTCs, maybe because of the bone marrow involvement as well. Some mutations are more related to involvement of specific organs. ESR appear to be closely related to liver involvement, and others may be related to lung involvement. So you can start really using liquid biopsy as a way not only to stratify patients, to select based on molecular feature the type of treatment, to monitor, also to figure out what type of imaging, what type of plan for monitoring you should implement based on the possibility of develop some metastatic sites due to the profile that you identify in the blood. So now we have introduced the concept of cell-free DNA and actionable mutations and CTCs. So let's start to look at the clinical value of the liquid biopsy in the individual patient. So how do you use this in the clinic when you have a patient that presents to you with metastatic disease? So I'm going to go through 2 cases because I think it will be representative of the power of this liquid biopsy information. So the first case is a 65-year-old postmenopausal Caucasian woman. She had a history of premalignant disease in 2006. She was continued to be monitored with imaging until she had some abnormality, calcification of the right breast in 2013. They required biopsy and, of course, surgical treatment. She had a lumpectomy. She had DCIS, ER positive, and then she went for bilateral skin-sparing mastectomy and immediate reconstruction with saline implants. But in December 2015, she noticed first a palpable lymph node in the axilla and some redness and firmness in the skin, the reconstructed breast. So this was, if you didn't know what happened before, we'll think about this as a primary IBC. She had an extensive redness, erythema, and palpable positive lymph node. The biopsy confirmed the lymph node was an invasive ductal carcinoma positive. So she was treated with chemotherapy with the idea that eventually she will have a additional local treatment as surgery, XRT, and endocrine therapy. So she did that, and then she started to, in 2019, did well till at that time, demonstrate an increase in LFTs, and now she has metastatic liver disease. The biopsy confirmed that the same type of disease we dealt before, and we did at this point a liquid biopsy and a CTC. And so you see the information here. She has an ESI mutation. The ESI mutation, as mentioned before, predicts for the liver metastasis. So this is confirmed. After many years of endocrine therapy, she had developed an ESI mutation. As a result of that, developed liver metastasis. But at the same time, she has a very high number of CTCs. In our lab, they also ran the HER2 test in the CTC. We found that she had 2+ CTCs and 1+ CTC. A large number of cells were in fact HER2 positive CTCs. So what do we do with this information? Well, when you are facing a disease like this, liver dysfunction, extensive liver involvement, you want to do the best that you can for this patient. And the best that we can is obviously a combination of chemotherapy and biological agent. We knew that she had no chance in endocrine therapy anymore, having developed a resistance, and that she had large number of CTC qualify her as stage 4 aggressive, and now we have a target in the CTC that is there too. So we felt that this patient should be treated with a combination with HER2 targeted therapy. So she was started with a combination of docetaxel, herceptin, and pertuzumab. And believe it or not, her CTC went to 0. Obviously, the HER2 CTC disappeared. This is the result of the PET-CT after she received 3 months of treatment. She has continued to do well for 9 months. If patient was going to receive unselected therapy, chemotherapy only, at the time of the first PET, she would not be alive by now. That's another case that I would like to bring to your attention because this one combined, again, the information from the two modalities. A 62-year-old postmenopausal woman diagnosed first in 2005. She had a mastectomy, axillary dissection, was a stage 2 disease, lobular cancer, grade 2, and ER/PR positive. She had adjuvant chemotherapy, TAC, docetaxel, doxorubicin, cyclophosphamide, and then tamoxifen for 1 year, and then went on letrozole, so long time endocrine therapy. She then went on observation, and in 2017, you're talking about this is a late recurrence again, she started to develop some bone pain. And this resulted in identification of metastatic bone disease requiring radiation therapy first to the cyst spine, and after that started with first-line Ibrance with letrozole in December 2017. She did not respond. You would not be surprised probably because this is a disease that had been already treated with endocrine therapy. And she was placed in capecitabine for a short time with no benefit. So she had molecular tests when she presented to our clinic, and this is what we found out. So she had a PI3K mutation, and she had CTC, and again with a portion of this CTC that are HER2 positive. So how do we interpret this information? She has a stage 4 aggressive. At this point, the disease is aggressive, likely to be resistant, and she does have an HER2 component, but most important, she has an actionable mutation. It's a PI3K mutation. This was shortly after the drug alpelisib was approved. So this is the presentation at the time of the tests where she had extensive liver disease, once again with the PI3K actionable mutation, and CTC 13 with 11 of them HER2 positive. She was started on faslodex and alpelisib, and this is what we have 3 months afterwards. So the patient had response immediately to the targeted therapy that was identified by the liquid biopsy. And the CTC dropped. And when she progressed, actually she had still CTC HER2 positive. And that time, we actually did another biopsy, and she was found to be also HER2 amplified. In this case, the HER2 was present in the CTC before we actually found out in the liver biopsy. Just to say that the most aggressive form of breast cancer here stage 4 aggressive with HER2 expression and also with a targeted PI3K mutations is an important opportunity for patients otherwise candidate for second-line standard of care. We just have a paper coming up today looking at the CTCF2 prognostic value and predictive value in patients that can benefit from HER2 targeted therapy. So just a quick word regarding alpelisib. This is obviously very important for us, particularly when we use the NGS or any liquid biopsy to identify this mutation in patient with hormone receptor positive disease. This was the first time that we had a biopsy targeted therapy approved, not only with a mutation detected on tissue NGS, but also with a blood-based NGS, the TerraSkin PI3K. But most of our patients actually receive testing with Guardant or any other NGS test. And when you identify this mutation, you can certainly prescribe this medication for these patients. This is based on the SOLAR-1 study, where they found out that alpelisib improved the progression-free survival only in the patients that have a mutation in the tissue. And these are patients that were also evaluated for cell-free DNA. And a very small group of patients of this study were exposed to CDK4/6, but in spite of that, it's becoming more and more standard of care to use alpelisib after a CDK4/6 when do you have the PI3K mutation. And this is the data with the actual detection of mutation in cell-free DNA. You see the difference in progression-free survival compared to the tissue. It was 11 versus 5.7, 10.9 versus 3.7, meaning that at the time of biopsy, when you do have a liquid biopsy indicate these mutations, clearly you may have a more aggressive disease that needs to be treated with a combination. And of course, this patient may have more than one mutation. Just for right now, we are focusing on one, but the complexity of endocrine resistance at the molecular level requires a little bit more attention and more study. So if CTC detection is bad for patients, how much uglier can metastatic become? And over the last 10 years, we actually started looking into clusters. When you have the ability to look into these images from the cell search, you actually see that there are situations where you have more clusters. Usually the clusters are associated with patients that have a larger number of CTCs, and these patients do typically worse. And we're trying to study the adhesion molecule responsible for the formation of these clusters. So we look at this question regarding the presence of the cluster in the concept of CTC detection, how this correlates to the liquid biopsy with, for example, cell-free DNA. Trying to find any hint of correlations that we can probably use for a therapeutic strategy. So we had samples from 26 patients that were included in these prospective biomarker studies. The cell search obviously was used for the CTC clusters and single cells, and we used a different technology, Predicin Plus, for cell-free DNA. And we look at this correlation. For example, there are 2 positive CTCs appear associated with HER2 mutation. This was very interesting because right now, when we see an HER2 CTC positive, we have to look for not only FISH amplification, but also HER2 mutation. This patient, of course, may have also a targeted therapy available to them with neratinib. And then the CTC cluster were associated with alteration in CDH1. That is very common, as you know, in lobular cancer. Cyclin D1 and BRCA1 present in the cell-free DNA. And these are different information, but they are also associated, as you see, with the ESR mutation and CTC cluster. So there are a number of different mutations that seems to be indicating not only the site of recurrence, but also the possibility that these patients may have more cluster than single cells and indicate even a worse and more aggressive disease. So the conclusion now is that stage 4 indolent, I hope I convince you that CTC enumeration can identify 2 different groups of patients. Stage 4 indolent, less than 5, and stage 4 aggressive. And if we start using indolent and aggressive and no longer talk about CTC5, I think we do a better service to the overall field. And this identifies a subset of patients at totally different independent outcome, independent of subtypes, disease location, line of therapy. Very important. We can also look at HER2 expression, ESR mutation in the CTC, and we can also compare and combine, most important, the information with cell-free DNA. I think these are complementary tests, in particular for the most aggressive group of patients, the aggressive one, we need to identify this actionable mutation. This is the way we can change patient outcome. I showed just 2 cases where treatment was selected only in the base of the liquid biopsy, and that had an impact on their overall outcome. But I think a future study needs to really focus on how to use this information, and even stratification in clinical studies in phase 3 study will be very relevant. So this is the work of many in collaboration with many individuals. This is on the left side, our lab. A group of people that spends every day of every week, even now with COVID-19, analyzing specimens from patients. We need to thank the EPAC investigator and the MD Anderson Breast Oncology for the data set. We have collaborations outside hematology, oncology, and visiting scientists also that contribute to some of this data. We have a precision medicine OncoSET team that is really trying to implement a number of technology, including some of the CTC, but certainly most important, cell-free DNA and NGS. So our effort in trying to improve patient care based on the combination of molecular tests is important. And I want to spend just a few words about the International Society of Liquid Biopsy. I think our mission is the most important is to implement liquid biopsy for the usual clinical practice, and this across the different countries, and this is very important. And I think in some respect, more important that technology development has been done effectively in the last 10, 15 years. And this is the leadership team. I am honored to be the president of this society, Dr. Rolfo, specialist lung cancer, Dr. Soran, and Dr. Mendels. Thank you very much for your attention. I think hopefully I stay on the time and hopefully I stimulate some discussion. Thank you.
Thank you, Dr. Cristofanilli. As a reminder to webinar participants, if you have a question, please type it into the Q&A box in the control panel. And before we begin the Q&A, we'd like to ask attendees to take a moment after the webinar has ended to give us feedback by taking our exit survey. All right, we'll now start the Q&A. So our first question, can you tell us from which stage of breast cancer would you recommend liquid biopsy to be a reliable option, especially if you're not able to do a tissue biopsy?
Yes, so we're talking about the 2 different modalities, CTCs and cell-free DNA. I think every time I don't have a chance to do a tissue biopsy, I certainly use cell-free DNA as a way to identify the molecular driver of the disease. Very commonly for example, bone disease and estrogen positive disease, I want to know if the patient has ESR mutation, PI3K, or anything that can help me decide in planning the treatment. At the same time, these patients obviously are studied with CTC, as I show, so that I know if they have an aggressive or indolent disease. If I don't have an ESR mutation and I do have a low CTCs, I may be less aggressive, and also the number of imaging tests can be less. So I think stage 4 for sure. There are obviously a number of studies that look at the high risk stage 3 in terms of trying to identify patient have a recurrence. I think this is an important research space. Can you identify recurrence before imaging? Probably you could. Right now, we know from CTC studies that we can identify patients that have a higher chance of recur. We know also from cell-free DNA studies that probably these modalities are our ability to detect patients with high risk. Number of studies published or about to be published. This field is going to move very quickly, but it's not clinically standard now to perform this test in the early disease and acting on this particular information. So definitely stage 4 in the near future. Hopefully we can do in a more aggressive stage 3 disease as well.
And since early detection is so critical for treatment and survival, do you have any comment or any experience on the value of liquid biopsy for actually early stage non-metastatic disease?
Yeah, I mean, there have been a number of studies with CTC, for example, looking at the patient that received neoadjuvant therapy, after neoadjuvant therapy, a recurrence and the value of, for example, local regional radiation or additional chemotherapy or endocrine therapy. we know that detection of these cells in this setting, in early disease, is prognostic for sure. As I mentioned, there are some indications that the cell-free DNA may have complementary information and similar information, particularly when you have some resistance settings. So one of the areas where we're really trying to spend more time and more resources, for example, is when you have a disease, a high risk of recurrence, there's no response to neoadjuvant therapy. This is an area where many patients receive chemotherapy if they are triple negative or so. Identify the patients doing NGS or the mastectomy specimen. You can identify the mutations, and then you can monitor or can run a cell-free DNA test to see if that mutation is detectable in the blood. There is issues with sensitivity. More sensitive tests will come up, but they will tell right away if there is a residual disease that we need to address. And obviously, the next step will be to design the study that plan for therapeutic intervention only when we find cell-free DNA or CTC detection, and we don't have to wait for the disease to be evident by imaging or symptomatic by that matter. So I think this is the next step in trying to focus on the aggressive, highly risk of recurrence and try to design studies for that particular group so that we can improve the survival by acting before the imaging shows something.
Have you found that a different number of CTCs correlates with aggressiveness in different subtypes of breast cancer?
Well, of course, years ago we published a paper that showed that there are different levels of high CTCs, and the higher you have, the more aggressive disease you have, and even a shorter survival. I think, as one of the studies that we also showed, that patients have bone metastasis together with other site of metastasis, you do worse, and the CTC is definitely higher in percentage and number. So if you have liver and bone, it's much higher chance that you're going to progress very quickly and have a shorter survival than when you have bone only or when you have liver only. And this is not just an additive fact, but the fact that obviously there is a high possibility that these cells are present in the bone marrow and shedding and circulating and actually develop the liver as a secondary point. So you can almost trace back, if you were to draw CTCs at each time point after they have been diagnosed, you can see that different disease sites would be coming up at different time points. And of course, that would be partially related to subtypes, partially related to the presence of CTC. That's why some studies suggest that these are more stem-like or progenitor cells, or at least a component of it.
Have you ever done CTC testing on cerebrospinal fluid for patients with central nervous system involvement?
Yeah, that's actually a very good question. As you know, there are a number of European studies showing that you can detect CTC, you can run biomarkers on CTCs in the cerebral fluid. And we have done this sometimes in a few patients. Certainly, the patient where we had suspicious, but the cytology was negative, the running with the cell search identified these cells. And of course, we were able to make a definite diagnosis, obviously, and monitor the CTC, the cells in the cerebral fluid over time with treatment. I think some other companies are also coming up with a test specifically focused on liquid from the cerebral fluid, and also looking at the F2 expression in this. So I think it's an area of definitely far to develop, and especially when cytology is not sensitive enough.
In your experience, are CTCs or cell-free DNA more accurate for determining prognosis or predicting disease-free survival?
Oh, I think there is much more data on CTCs in terms of predicting prognosis and progression-free survival. I think the cell-free DNA, especially when you use the NGS, you do have different mutation, different combination of mutation, different allele frequency. I mean, it's a good tumor burden measure, and of course provide information for actionable mutations that you can monitor over time. But in terms of prognostic and value, I think the CTC is certainly an established value. And I think, we're talking about the CTC cell search, and it's so solid that that's the reason why I think we should consider the stratification in stage 4 and maybe not longer talking about 5 or more, because it's very confusing when you look at paper looking at CTC and other CTC technique, And how many cells you have? Well, I found 100 cells with this technology. I have more than what I have with the cell search. What does it mean? We cannot say it's the same information. Certainly, as a patient with CTC or metastatic disease, you expect to have CTC, but the short answer is CTC cell search is a strong certification, so it's much stronger than for prognosis for cell-free DNA compared to cell-free DNA.
So then to follow up on that, have you ever found cell-free DNA to reliably predict any particular clinical outcomes?
Yeah, I think this is something that we're just about to publish with regard to the ESR mutation and the liver metastasis and the most aggressive and even a hint of progression-free survival and possibly overall survival. You just need to have the numbers. I think ESR is becoming a very important mutations for hormone receptor positive breast cancer. That's why there is an effort in developing drugs that can be targeting this mutation after progression to endocrine therapy. I already mentioned that PI3K is more predictive and not prognostic. And this comes also from other studies in the past looking at tissue expression in metastatic disease. So these are the two most important. I think there are mutations associated with specific conditions like lobular cancer with F2 mutations. In some cases, F2 mutations being an expression of endocrine resistance in a late clonal evolution. And in that case, you can use targeted therapy, but you don't have to be beside predictive as there's no prognostic features for that. I think 4 or 5 mutations are extremely important for monitoring it for targeted in hormone receptor positive disease.
What are your thoughts on testing all patients, regardless of stage, with liquid biopsy and next-generation sequencing in order to treat with targeted therapy from the onset of disease?
So I'm a strong believer of liquid biopsy that one day will become the standard blood test, and everybody will do, from the moment that you do a mammogram for breast cancer patients, to do a biopsy, and overall over time. There will be probably different tests within the same family with different sensitivity, but I don't see any reason why, except for obviously the cost and the validation studies, we should not monitor breast cancer as we do for diabetes and other chronic conditions.
In the second case that you talked about, do you think you'd have been able to find the same mutations that you found in a liquid biopsy in a solid biopsy? And if so, how much more accurate is a liquid biopsy compared to a solid biopsy? And what would be the advantage of doing liquid versus solid?
Yeah, in that particular patient, there's no question that the tissue could have the same mutation in the liquid. But as for lung cancer, this was much quicker. In order for us to actually demonstrate that in the tissue was going to be the same mutation, we had to have a liver-directed biopsy, send the tissue out. It was going to take 3 or 4 weeks, typically. In this case, after a week, we knew exactly what type of therapy the patient needed to be treated with. So every time that there is no possibility of tissue biopsy, or when the tissue biopsy delays the standard of treatment starting, I think this is very important alternative. And I think liquid biopsy is great in that respect because also you can monitor if this mutation disappears from the treatment and targeted therapy, you have an impact on outcome, and most likely this is the driver of mutation. If it's not, certainly that's not the case. And tissue cannot be repeated. It's very difficult to repeat a liver biopsy in a patient that has a first recurrence and then progressing.
So in the last few years, there have been several studies focusing on resistance to CDK4/6 inhibitors. Do you think that CTC enumeration and molecular characterization in locally advanced metastatic HR-positive breast cancers could act as predictor of an intrinsic versus acquired resistance to CDK4/6 inhibitors?
Yes, I definitely think that if we were to design a next generation of clinical trials, we will need to really incorporate liquid biopsies for patient stratifications and for molecular characterization. I think there is a fundamental difference between the primary endocrine resistance and the secondary or acquired. And the longitudinal monitoring is important for the acquired secondary resistance. And that's the only way we can actually design a subsequent treatment plan for patient after recurrence. Ideally, you would like to design a study that incorporates the research question, in a sequential way. Many times we just go back and look at the type of therapy the patients had after they progressed from the study drug. And I think this is obviously informative, but it's not as informative if I had followed these patients, had already planned for the second line based on the molecular test, and I know exactly what the outcome. Potentially, you can develop 2 or 3 drugs in the same study.
All right, thank you. We have many more questions in the queue, but I'm afraid that that's all the time we have for today, so we'll have to end it there. We'd like to thank Massimo Cristofanilli and our sponsor, Menarini Silicon Biosystems. If we didn't have time to get to your question, we will try to follow up with our experts. As a reminder, please look out for the pop-up survey after you log out to provide your feedback. If you missed any part of this webinar or wish to listen to it again, a link to an archived version will be emailed to all attendees. Thank you for joining us for this genome webinar.
Thank you.